On behalf of the International Hyperhidrosis Society, Dr. David Pariser will demonstrate botulinum toxin injections for primary axillary hyperhidrosis.
Technique for axillary injections of botulinum toxin for treatment of hyperhidrosis, which is demonstrated in this video, is easily learned. Position the patient on an examination table with arms above his or her head and drape the patient appropriately. A starch iodine test may be used to identify the areas of hyperhidrosis and is helpful to document the areas of the most active sweat production. First, wipe off any residual sweat or other water from the axilla. The presence of any water on the skin will give a falsely positive starch reaction. If the iodine is applied by using a betadine swab, be sure that it is completely dry before the application of starch to avoid a false positive reaction. Using a shaker or sifter, dust cornstarch onto the axilla and wipe off the excess starch with a gauze pad or a small brush, such as an artist's brush or makeup brush. Wait 3 to 5 minutes for the reaction to occur. When positive, a blackish discoloration will develop, first as dots from individual sweat glands, and very soon as a confluent dark stain. Some patients may not be perspiring at the very moment of the starch iodide test, particularly those who have been previously treated. In this case, inject the entire terminal hair-bearing area of the axillary vault. A surgical marker may be used to identify the area to be injected. Injection sites should be made about 1.5 centimeters apart. The use of a pre-made grid may be helpful in identifying the injection sites. The 100-unit vial of botulinum toxin should be reconstituted with 4 ml of diluent and loaded into 4 1 ml tuberculin or insulin syringes. Be sure to use a syringe with a luer lock so that there is no loss of toxin from needle separation from the syringe. Some injectors prefer to use insulin syringes with permanently attached needles, which do not waste a drop of the toxin in the hub of the needle. Injections should be made into deep dermis and superficial subcutaneous tissue. Inject between 0.05 and 0.1 ml, which should deliver about 1 to 2.5 units of toxin at each injection site. Continue the injections until the entire grid pattern has been completed. A total of 50 units of toxin should be injected into each axilla for most patients. In some cases, more than 50 units may be needed, especially in men, or for repeat injections when the 50-unit dose did not give satisfactory relief.